So welcome to everyone. Welcome by our EuroELSO webinar. Today we will have three speakers and excellent regarding ECLS in accidental hypothermia. My name is Justyna Swol. I am the chair of the EuroELSO Scientific Committee and a co-chair of ELSO Registry Scientific Oversight Committee. I'm also an associate editor of Artificial Organs and Perfusion and adult intensivist. As I introduced before, we have three speakers, and we will start with Sylveriusz Kosinski from Poland. He will speak about pathophysiology of hypothermic cardiac arrest. His background is anesthesiology. He's a specialist in intensive care with expertise in ECLS and post-resuscitation care. His clinical work focuses on trauma, orthopedic and thoracic anesthesia, as well as pain medicine. He is also a mountain rescuer and a former chief medical officer of Tatra Mountain Rescue Services and co-founder of the Severe Hypothermia Treatment Center in Poland. Next speaker will be Konrad Mendrala, who will speak about eligibility criteria in ECPR in hypothermic cardiac arrest, and Professor Mathieu Pasquier, he will be talking about the HOPE score, and I will introduce you both before your presentation. So I would suggest to start with Sylveriusz and his presentation, please.
Thank you very much. Can you see my screen?
Yes.
Thank you. Well, thank you for the invitation. I'm just honored to be among such a distinguished group. However, I'm aware that I'm only a support for the next speakers. There is a chain of survival in hypothermia, but it's very simple, so I won't waste your time. Maybe there will be any questions I could answer after the lecture. And here in turn, huge differences which exist between normothermic and hypothermic cardiac arrest. Remember, all these issues, all these situations, the ECLS should be considered with very good outcomes and very good neurological outcome. What are the predictors? In general, the risk of HCA increases at temperature below 32, and it's believed that hypothermia is unlikely the sole cause of cardiac arrest in patients with TC above 28. For example, Charlene Frey observed that CA occurred in patients with a mean temperature of 24. Traditionally, methods to stratify the risk of cardiac arrest have been based on core temperature. However, in the pre-hospital environment, reliable measurements of core temperature are often not accessible. Simple clinical predictors of cardiac arrest are constantly sought. Among these, the most useful may be the level of consciousness, the hemodynamic instability, and recently oxygen delivery and ABG disturbances. From the pathophysiological point of view, body temperature should be the strongest predictor of HCA. The lower the temperature, the higher the risk. However, in clinical practice, a huge inconsistency between TC and hemodynamic status can be observed in clinical practice, as there is a group of patients who avoid HCA, despite a very low TC. Matt Pasquier demonstrated that hemodynamic status and consciousness level very good correlate with core temperature, with the latter showing the highest correlation. no patients with a normal conscience level suffered cardiac arrest. Charlene Frey found that the patients who arrested had a GCS below 11. And based on this observation, the revised system for clinical staging of hypothermia was created. This is on the screen on the down. Samuel Barrow wrote, the consciousness level predicts cardiac arrest at least as well and potentially better than core temperature, although possibly at the expense of more false positives. However, in the recent study, our friend Paweł Podsiadło stated that 1/3 of the patients who sustained HCA were not unconscious on initial assessment. Further, we have cases described of maintaining consciousness during cardiac arrest and resuscitation, called CPRIC, in profound hypothermia. And this further complicates assessment of interpretation of GCS and impacts the usefulness of assessing the level of consciousness alone. I said alone because we need urgently sets of predictors, not a single one. So what are the cardiovascular symptoms? Because to discuss hemodynamic instability as the next point, as a predictor of cardiac arrest, one must first understand the cardiovascular symptoms. So let's start with level below 32 degrees. It's possible sinus bradycardia, prolonged QT interval, atrial fibrillation. On the margin, we should be prepared for any rhythm and expect to be not possible to treat them until the heart rewarms. Next, below 28 degrees, fall in pulse rate about 50%, high likelihood of ventricular fibrillation, and the deep, severe hypothermia, profound hypothermia, minus below 24, cardiac output falls to 45%, and vasoconstriction falls. So what is the first recorded rhythm in HCA? Based on the two recent studies, it seems that defibrillation rhythms are met in about 2/3 of our patients. Both the temperature at which defibrillation can be effectively used and how often it should be repeated in hypothermic patients have not been definitely established. If VT persists after 3 shocks, it's recommended to delay further attempts until TC rises to about 30 degrees. It's confirmed by a recent European Resuscitation Council recommendations. So in some cases, however, it may be reasonable to perform further defibrillations. Why? Because it's unclear whether the likelihood of successful defibrillation is increased by an increased or core temperature or by the increase of myocardial perfusion. We have here the example of successful defibrillation at 18.2 degrees. What that can say? Active warming can improve defibrillation success and improve coronary perfusion pressure with VA ECMO. And this might be crucial. And comment at the end of this section, the current recommendations of scientific committees of European Resuscitation Council are very sound for me, and I don't mean to argue with them. I show this case because I try to pointing out a gap in our understanding that needs to be explored maybe in the future. What is the rescue collapse? Severely hypothermic patients are prone to rescue collapse. Traditionally, it was described in the water rescue, and this sudden deterioration of the patient on initial management is frequently seen also in the land environment, especially in mountain rescue. There was a number of clinical examples of victims being rescued from the cold stress in an apparently stable and conscious condition, only to experience a cardiac arrest. The pathophysiology behind the rescue collapse is not clearly understood, but it's likely a combination of afterdrop. I will talk about this later. Catecholamine changes or movement-induced arrhythmias in an unstable myocardium. Clinical observation, including mine personal, also show that sudden changes in respiratory parameters may be important. The incidence of rescue collapse in mountain rescue may be about even 50%. It's the data from French Alps, but in urban environments may be seen in 35% of patients. However, it is unclear whether rescue collapse is a dramatic incident which worsens a patient's outcome or an obvious consequence of hypothermia without any impact on treatment results. It's very interesting to divide the two situations because a rescue collapse might be associated with a favorable outcome, especially in the case of avalanche victims. At least two papers confirmed that. However, recent reports from Europe and Japan found that the risk of death in patients who sustained rescue collapse is twice as high as in HT3 patients. So it's symptomatic. Here we have a classic and new based on the recent studies, signs of circulatory instability. Classic signs include hypotension with SBP lower than 90 millimeters mercurium and ventricular arrhythmias, while new signs include bradycardia, heart rate below 45, associated with ventricular arrhythmias, and this is specific for pre-hospital setting, and bradycardia with hypoxemia and low BE in the hospital setting. And what do you have I mentioned about afterdrop is a strange situation and in general undiscovered. It's the continued drop of core body temperature after a victim has been removed from the cold. It's believed that this occurs because cold blow from the periphery returns to the core after the vasodilation begins during external rewarming. This led to a further decrease in core temperature. Well, a small decrease in core temperature after the initiation of rewarming is a thermodynamic fact for any solid body with a warmer core and cooler surface. But the humans are more complex, as circulation can cause convective heat transfer and conductive, and various tissues can produce heat. although after drop of as much as even 5 to 6 degrees has been reported, and several reports have failed to demonstrate any temperature decrease in patients during rewarming. It must be noted that in clinical practice recently, as the severity of hypothermia increases, a hospital rewarming is performed less frequently, except maybe traumatic hypothermia. And this highlights difficulties in assessing the cause and significance of the drop, and at least in pre-hospital environment. And in hospital environment, after drop is of course possible, but rarely spoken. As far as I know, Konrad will discuss the acid-base balance interpretation extensively. So I will focus on the basics. In clinical practice, we tend to interpret ABG using uncorrected values. It is based on the clinical practice, on literature, but this is usually because we pay more attention to carbon dioxide tension as a regulator of cerebral blood flow, as sensitivity to changes in carbon dioxide tension is maintained even in profound hypothermia. However, we rarely pay attention to oxygen tension, which can be decisive and very important in certain situations. Look at this observation by Paweł Podsiadło. And this observation is consistent with at least 3 recent studies that showed that monitoring of hypothermic patients, which is oxygenation with uncorrected values of PaO2, can lead to false conclusions. For reference, please refer to Paweł's study. Oops, too far. And what about oxygen delivery? At 25 Celsius degree, hemoglobin nearly ceases to release oxygen, and its role as active oxygen carrier becomes minimal. And then with dissolved oxygen accounts for about 84-85% of oxygen supply. And usually the restoration of circulation results in high lactate concentration. So there is a peak in the beginning and subsequent downward trend in lactate clearance. And this is usually associated with a more favorable prognosis. Oxygen consumption and carbon dioxide production fall by about 50% at 30 degrees. If a sensitivity, when a sensitivity of to CO2, I'm sorry, it's a Polish word, and CO2 is blunted, although the hypoxic drive is maintained to deeper levels of hypothermia. So we should ask, where do high lactate levels and base deficit in our patients come from? Is the oxygen delivery truly adapted to consumption? What happens at the cellular level? Why, with seemingly optimal gradients, mitochondria switch to anaerobic mode? We don't fully understand this, but I hope that future studies will show us the explanations. Hypoxia was suggested at HCA precipitating factor as long as 50 years ago by classic, but even Lloyd. But some recent studies suggest that lower arterial oxygen pulse pressure is associated with the higher risk of cardiac arrest. A comment should be further research is needed. What about acid-base balance further? Paweł Podsiadło reported that different factors are associated with survival in the HT3 and the rescue collapse group. The model, including patient age, rewarming rate, and blood-based excess, was the most accurate set of factors in the HT3 group. However, in the RC group, in rescue collapse group, the strongest association with survival was patient age and serum lactate. So, as you noticed, in the latest 15 minutes, I mentioned about base deficit, about serum lactate rather frequently. So, what is the role of buffers? The colder the organism, the colder the human, the greater the role of the proteinate buffer with alpha imidazoles, while the CO2 and bicarbonate plays a secondary role. The marked change in the base deficit during rewarming with ECPR indicates that bicarbonates came into action with alpha imidazole buffering maintained, providing something which we can call a buffering boost. So the gradual increase in bicarbonate during rewarming in survivors and decrease in non-survivors are very symptomatic in these situations. Let's say a couple of words about bicarbonate because it appears that this is very important. Reabsorption of bicarbonate depends on renal blood flow and ATPase activity. The fact that RBF is reduced in severe hypothermia is self-evident, is obvious. In turn, both animal and transplant studies indicate that ATPase activity is significantly reduced, thus completely disrupting active transport and regeneration of bicarbonate. All this may indicate that the role of kidneys in HT3 is very important. Perhaps the effectiveness of warming during kidney replacement therapy stems not only from heat delivery, but also improved bicarbonate exchange and more effective regulation of acid-base balance. Please treat this consideration as theoretical, as the few human studies, if any, have addressed this issue. And the last slide, because I am over time, some words about organ dysfunction and reasons for cardiac dysfunction. It seems that the key factor for organ dysfunction and cardiac dysfunction plays impaired regulation of cytosolic calcium concentration. I wouldn't dare to interpret the mechanism from the diagram of this diagram because I barely understand this mechanism myself, and I'd rather leave it to Torkel Feita. However, I would like to recommend the excellent review by Torkel and Gary Sick for your own analysis. So the resulting of this processes calcium overload might negatively impact the heart contractile response over time, and elevated cytoplasmatic calcium increases. Energy consumption causes mitochondrial depolarization, breaks down the oxidative phosphorylation, causes oxygen ROS formation, compromise energy production, and in turn causes a cell death. And perhaps that is the reason why we cannot save all our patients. Thank you very much.
Thank you so much, Sylveriusz. So for our webinar attendees, I would like to mention that this webinar is recorded and will be available on the YouTube channel of EuroELSO, so that you can put your questions and answers to our section Q&A, and we will discuss after the third presentation. I have just one question in between, Sylveriusz, about you and your activities in the Polish mountain rescue. So you have coordinated one of the longest rescue operation of the hypothermic cardiac arrest patients. What was for you or for the team the key to success? What is the most important key element of the hypothermic chain of survival when you could recommend it to other colleagues, please?
Excuse me.
No problem.
I think the critical factor in this situation you mentioned and other was a position of hypothermia coordinator. I think the coordination of such a huge rescue operation was critical. I must say that our rescuers in the Tatra Mountains are very well trained, and they know what should they do, and they are well. They did every possible effort to save Catherine. That was her name. So that was a very important factor. The creating such a position was very important. And the other thing I must say that Catherine was a fighter. She is a fighter. When she was discovered from the snow, she was conscious. Her GCS was about 12, and no one expect that the cardiac arrest really occurred. Rescuers did every effort, as I said, to protect her from further heat loss, but it happened. So coordination, will of fight, and the second and third factor, the protective mechanism of hypothermia. That was decisive.
Thank you, Sylveriusz. And let us move now. So there is one question about the experience in pediatric practice. So maybe very shortly, I would move this question at the end of our webinar, and I would like to ask all three speakers as well. So we will move now to the next speaker. It's Konrad Mendrala. He will be talking about the eligibility criteria for ECPR in hypothermic cardiac arrest. He is also anesthesiologist and intensive care physician, an assistant professor of cardiac anesthesiology na Uniwersytecie Medycznym, na Śląskim Uniwersytecie Medycznym. w Katowicach w Polsce, Katowice, Poland. And his clinical and research interests include ECLS and use of modern data analytic methods to improve prognostication in critically ill patients. So please, Konrad, start your presentation, and we are looking to your presentation.
Hi, thank you. Thanks a lot for the invitation. Can you hear me, and can you all see the screen, please?
Mathieu, if we cannot see Konrad, is it right? So maybe we could continue with your presentation, please. So Mathieu will talk about HOPE score. Mathieu Pasquier is a senior researcher in emergency medicine and in a university hospital in Lausanne in Switzerland. He specialized in advanced life support in emergency care, and his research focuses on pre-hospital management, particularly the development of new treatment strategies for patients with accidental hypothermia. He led the development of hypothermia outcome prediction score after extracorporeal life support, the HOPE score. And this score is recommended in the international resuscitation guidelines to support ECPR initiation decisions in hypothermic cardiac arrest. So please, Mathieu, we are looking forward to your presentation.
Thank you. Can you see the slides?
Yes, we can
hear
see
me.
them.
Excellent.
Yes, we can hear you.
So thank you for your kind invitation. And briefly, I will introduce you or remind you some elements about the HOPE score and derivation validation study, and focus also on the clinical consequences of such a score and some very practical aspects at the end. So as you maybe know, the indication to ECLS rewarming for hypothermic cardiac arrest patient was, until a few years ago, done using the potassium. So patient came on cardiac arrest to the hospital, and then we made a blood sampling for potassium. And if it was very high, it was considered as non-indicated. So people were left dead, so no ECPR, no rewarming. And if the potassium was normal or not so high, so there was an indication to ECLS rewarming. And then after rewarming, some patient would die, unfortunately, and some would survive with good neurological outcome most of the time. So there were some limitation in this potassium-only approach. It was a dichotomic structure of the algorithm, first the temperature and then the potassium with some cutoffs. There are some limitation in the potassium sampling. It was based on a very low evidence level, basically some case series 30 years ago, and many potentially important variable, notably variable related to cardiac arrest, were not included in the model. So the idea and the ground of this project, which was the HOPE score study, which was led here in Lausanne, but with a lot of people around the world and teams. It was to build a retrospective registry, basically, of hypothermic cardiac arrest patients who were rewarmed with ECLS. And we included not only published case series from different hospitals and teams, but also unpublished cases from several hospitals in the world. So we were able to build a retrospective registry with 286 patients. And what was the outcome? What were the outcome of these patients who were all rewarmed with ECLS? It was 37% of survival, and we had a bit more than 100 survivors, which allow us to make some powerful enough statistical analysis for a multivariate model. So these are the outcome, and the neurological survival is excellent for most of this survivor. So enough power. It was the good news with this first HOPE, the derivation study, and consecutive cases in a given time frame. So it was built to lower the publication bias of, for example, case report, and also to select people patients who also would have bad outcome to lower the selection bias. So we were able to include all variables that we wanted to include at this time. So some classical confounders, possibly in medicine, the age, the sex of the patient, some variable related to more specifically to hypothermia, so the mechanism, was there an asphyxia, I'm thinking about avalanche victims or drowning, and also the potassium, which was the historical criteria, and the temperature of the patient, of course, and also variable related to classic cardiac arrest, which were the CPR duration, the fact whether the cardiac arrest was witnessed or not, and the cardiac arrest rhythm, which are classic predictors in cardiac arrest, and also the rewarming method, CPB or ECMO. So we put this in the model, and we selected, or the model output was the identification of those 6 variables, which are independently associated with the outcome, which was in the HOPE derivation studies, the survival to hospital discharge. So the 3 other variables here are not independently associated with good outcome when taking in consideration all these other variables. So this is a quite complicated and not very friendly equation here. So we made a simple online calculator on this website, which help you to calculate the survival probabilities of a given patient that you have in your hospital at admission in cardiac arrest and hypothermic. So what are the performance of a score? You know this. We first look at the discrimination. So will the score make a good separation between the patient who will survive or not following ECLS rewarming? So you have the score here on the vertical axis, 20%, 40% survival probabilities, and visually you can see that the discrimination is quite good between the 2 groups. And which is maybe more important, it's better than the potassium alone. Here, on the right panel, the red line. So the AUC of the HOPE score in black is much better than the historical criteria. And we decided or proposed, looking at the survivors, to use a cutoff for 10% of survival probabilities, because as the neurological outcome of survivors is excellent, we want to catch all potential survivors. So it was a bit lower than the lowest survival probability of a patient who survived in the HOPE derivation study. So the clinical consequences of this, if you put here the 2 criteria, the historical one, which is potassium, and the HOPE score using a cutoff at 10%, you can see that you will still have, it's expressed in terms of percentage here. You can still catch the survivors, the 37% of survivors when using the HOPE cutoff at 10%. And on the other side, you will avoid quite an important number of unnecessary rewarming of patients who will ultimately die. So one of the first and main consequences of the application of the HOPE score compared to potassium is to lower futility and the number of unnecessary ECPR rewarming of patients who will ultimately die. So we made a retrospective study using in 3 different hospitals, applying HOPE for patients who were not rewarmed. So it's a potassium here, which was used to decide or not to go to ECLS for this cardiac arrest patient. And you can see here, those patients in green were not rewarmed. The clinicians followed the historical guidelines, and in red here, the patients were not rewarmed also, but without following the guidelines. If you use retrospectively HOPE on this different patient, what you see is that, again, using a cutoff of less of 10%, this will have supported the decision, which was possibly good, hopefully good of the clinician, but this will have supported the clinical decision in 13 of these cases. So again, this will help not to rewarm people which would have will have a bad outcome. So the second parameter in the score is a calibration, and we were happy to be able to do an external validation study, which is quite not so frequent for clinical scores, and we included 122 cases, which survived with a survival rate of 42%. And when applying the HOPE score globally, you can see that in this cohort, the survival was 38%, so very close to the 42%. So the calibration was good. The AUC was a bit lower than in the derivation cohort. And then regarding the other parameter, you can see here that we have a patient. It was a child, which was, it's not very clear the mechanism between asphyxia or not, but he survived despite having a lower probability, HOPE score of less than 10%. So this explains the negative predictive value, that is not 100%, but 97, which is still pretty good. And visually, you can also see here and prove statistically that the discrimination, the calibration, sorry, is good, because the predicted survival here of the 122 patient is very close to the observed one. So the calibration is good. So how does it help us to have a good calibration? We made this time also a retrospective study of two hospitals, mine in Lausanne, which is a university hospital, the CHUV here, and another regional hospital more in the mountain, but also equipped with ECLS rewarming. And we calculated the HOPE score of patients who were this time rewarmed with ECLS. And like in my hospital here, we had 26 patients, in the other hospital 19. And you can see here, if we retrospectively had used the HOPE score instead of the potassium, which was historically used, we still would have selected the survivors for ECLS, but we would have avoided 38% of like unindicated rewarming of people who will ultimately die. So it's quite interesting. There are some limitation in this approach, but what is also a bit conceptual and interesting, I hope, I find, is that if you check the survival by hospital, we had 33% of survival, and they had 11. But if you check the HOPE score, you can see that our predicted hospital, for example, in my hospital, was a bit higher. So internally speaking, like internal quality control, we could, or it stimulates us to do better. And you can also see that there are differences between the two hospitals in the predicted survival, because the case mix is different. And the main reason is that in this regional hospital, they have much more avalanche victims, so much more asphyxia. So predicted survival for the patients that are rewarmed there, the prognostic, the global prognostic is not as good as predicted in my hospital. So it may also allow for benchmarking between some case mix using HOPE, the HOPE score globally, and not for a single, not only for a single patient. The other effect of the good calibration is to lower the under triage, because there are not so a lot of patients with accidental hypothermia. So when you have a predicted probability that you can read on your smartphone, then it will motivate the people to go and to select the people with some potential for survivals. And I had a feedback, for example, from New Zealand a few years ago. We won for the first time their first patient in Auckland with ECMO, using the HOPE score to motivate the people who put the ECMO, and she survived. It was a young woman. Another case, maybe there are some people from Barcelona here, but we won their first patient also a few years ago, not using the HOPE score or the potassium to qualify this patient for ECMO, but she had RUSC following rewarming and multiple complication, and they used, which is a good way to also to use HOPE, the predicted survival as in the balance to decide to continue or not the ICU course, which was complicated. And I speak about a case I had to manage with the pre-hospital helicopter rescue a few months ago. It was a young patient, 22 year old, who was found emerged. He wanted to escape to the police during the night, and he was emerged in a small swamp, like a very small lake. He was still reactive to pain, and when he was rescued by the policeman, the paramedics and so on, they tried to take him out of this swamp, and at this moment he was a bit submerged, so 3 minutes ahead under the water, and when they extricated him, he was in cardiac arrest in asystole, so they begin CPR. We arrived, the patient was intubated, the esophageal temperature was 22.9, and then we arrived in my hospital a bit later. We were not called at this moment, a bit later, and the potassium was 5. So we made a HOPE score, and just to see you how it works practically, you can put the age of the patient, here 22. It's a mechanism initially without asphyxia, because he was called before to be submerged, 2 hours of CPR duration, the potassium and the temperature, and then the output is survival probability. For this patient, it was 53%. So our heart surgeon put the ECMO, but there was a lot of complication and a lot of sludge and thrombus. The ECMO didn't run very good. So it was a big discussion. What do we do now? And motivated also by the value of the HOPE score, it was decided to put a central ECMO in the operation room, and then to aspirate those thrombi. It was complicated, so the patient was cooled down again to do this, and then we warm again, and then sinus rhythm 1 hour later, basically, and then complication again, massive transfusion protocol, tamponade, and so on. But 4 days via ECMO, 12 days VV ECMO, and then transfer to the ward, and an excellent outcome without any sequela. So you can also use the score to put this in the balance when deciding to continue, or is it futile or not, for people who made sometimes important complication. So the strength of the HOPE score is quite innovative methodology to lower the selection bias. It was one of the first multivariable model. It was proved better than the potassium, which is a historical criteria, and it helps us to improve the decisional process. And more than a score, it gives you a well-calibrated estimation of the survival probabilities, which you can use to decide clinically. Just quickly, some words about the variable. The free one in green, it's quite easy to estimate them if you don't have them or to measure them. CPR duration, just remember that it's in the derivation studies, a CPR defined from initiation of CPR until the ECMO runs. So you have to add some minutes in your context. And regarding these two variables, they have a very high heavy weight in the equation. And just remember, I just put the reference here, potassium is subject to a lot of analytical bias. So try to be as atraumatic as possible when drawing the potassium samplings. Take them rather in a vein than in an arteria, and avoid hemolysis, and including you are allowed to stop briefly CPR when doing some blood samples to avoid trauma and have a very good quality of potassium. Another variable that is quite complicated to manage is the mechanism. Is it with or without asphyxia? I think about avalanches. I think about drowning, immerse, submerge. What happens? The story is not clear all the times. You know this. So if you have any doubt between asphyxia or not, you can consider doing the two calculation with or without asphyxiation, and to discuss also regarding the pre-hospital information you have, and then you can choose for your patient which scenario you can use to avoid underestimation of the survival probabilities and to select the patient adequately. So in the recommendation this year, the ERC mentioned the HOPE score as a tool to help decision in deciding which patient go to ECLS. In the AHA, they also mention the HOPE score with a cutoff of 10% for the adult, and also even they propose a cutoff of 5% as a possibility in children. There is this beautiful article in the JAMA who compare different scores, and maybe Konrad will speak about this. And finally, the ELSO guidelines, which, and it's very important, state not only that you can use a HOPE score, but also that the entry in the algorithm or the decision is first you have to be hypothermic and with a temperature below 30. Thank you for your attention.
Thank you, Mathieu. So I do not see any questions in our chat, despite this question about the pediatrics. So I would suggest, so Konrad is back. There were some difficulties in the connection. Maybe you could try to switch off your camera when sharing the screen, so it might be not such a huge data volume. And then we are looking forward to your presentation.
Okay, nice to be here again. So I'll try to share my screen. Hopefully it will work. Okay. So as Professor Kosinski showed us, the accidental hypothermia is a separate clinical condition, and it does not follow the same rules as normothermia. On one hand, we have a serious problem in the emergency medicine. It increases the risk of complications and of the cardiac arrest. On the other hand, we have a low temperature that protects the brain, and because of this neuroprotection, we sometimes can go beyond the usual limits of resuscitation, as Mathieu showed us. In hypothermic patients, ECMO is one of the few true therapies. So here, ECMO is not only just the cardiac support or the oxygenation support, it is an active rewarming method. So in CLS, in hypothermia, actually covers two different groups of patients with hypothermic cardiac arrest, which are today's main topic, but also the patients who still have circulation, but they are hemodynamically unstable. And just to be clear, we still don't know if it's good to patient to put him on ECMO with preserved circulation. We have two main studies at this area of interest, but very hard to compare because they have different populations, different hypothermia presentation, different definitions of hemodynamic instability and different age and so on and so on. And in one study by Professor Podsiadło, ECLS increases the survival by 20% with no clear increase in major bleeding and complications, while in Japanese ice crash registry, the unstable patients on ECMO had almost the same survival, but with many more bleeding complications. What we do know actually is that the clearest indication for ECPR is hypothermic cardiac arrest. So in this multi-center registry SAFE-J study of out-of-hospital cardiac arrest patients, when they compared etiologies such as cardiac causes, trauma, PE infections, they found that the patients with accidental hypothermia actually had the best prognosis. And after adjustment for age, sex, witness arrest, and for CPR time, the accidental hypothermia had about 5-fold higher odds of both survival with good neurological outcome and overall survival compared with the cardiac process, which was the reference group. What is the most important that those patients, those hypothermic patients, actually looked much worse before ECPR. They were less often witnessed, they had fewer shockable rhythms, they were slightly older, and they have longer cardiac arrest to ECMO intervals. So if the hypothermia is the primary cause of cardiac arrest, ECPR offers a much better chance of survival with good neurological recovery. And as Professor Kosinski said, it is because so-called the Q10 effect. So when you cool down the body by 10 degrees, you reduce the cerebral oxygen consumption by approximately 50%, and that is the fact that increases the safe hypoxia time. It's not the science fiction, but it is not that every patient in cardiac arrest is a good candidate for ECPR. So the key question is in HCA, who should not go on ECMO? So first, let's see what I have to move. Justine, sorry. First, let's see what ELSO suggests for normothermic cardiac arrest. So here we are very strict. We want witness arrest. We want an indistinguishable shockable rhythm or PA rhythm, no flow, no more than 5 minutes, and the possibility to start ECMO within approximately 60 minutes. We also want ETCO2 above 10 millimeters of mercury, no life-limiting comorbidities, and for technical reasons, no more than mild aortic regurgitation. For hypothermic cardiac arrest, the new ELSO consensus actually changes logic. In hypothermia, the target population is typically the patients with the temperature below 30 degrees and with predicted survival of at least 10% based on the HOPE score. And in these hypothermic settings, the factors that are contraindications in normothermia are no longer the absolute contraindications. So the unwitnessed arrest, the asystole, the prolonged CPR, low ETCO2, and so on. What does not change actually are the true limiting factors. So the patients with end-stage comorbidities, with very poor pre-arrest function status, with significant aortic valve regurgitation, are unfortunately still poor candidates for ECPR regardless of the temperature. So when we think about the ECPR in HCA, we should move away from this simply cutoffs like time and rhythm and just focus on two things instead. A realistic chance of survival based on the HOPE score and the absence of life-limiting comorbidities that would make this survival with good quality of life seriously unlikely. And where does it came from? So if we look at those criteria one by one, the unwitnessed cardiac arrest is usually the most powerful and strict contraindication for ECPR in normothermic patients. But in hypothermia, this is different. From over 200 patients with unwitnessed HCA, almost a quarter survived, and most of them had CPC 102, so good neurological outcome without any serious neurological defect. CPR before ECLS was very long, exceeding 100 minutes in both groups, which is much longer than suggested in normothermic guidelines. And beside that, we have unwitnessed and long CPR. Almost half of the survivals had asystole as the initial rhythm. So, yeah, I think this is truly amazing. Similar pattern we can see in those 4 studies. So the Saczkowski meta-analysis that led to creation of the I-score, the Pasquier HOPE score, both the derivation and validation cohorts, and the recent non-asphyxial cohort from Paweł Podsiadło. They are all the cornerstones of the hypothermic ECPR. And compared with normothermia, those patients would usually be excluded from ECMO. As you can see, CPR duration was around 2 hours on average in all these studies. The asystole was about 50% of patients in the I-score and the HOPE studies, and 1/4 in Paweł Podsiadło study. And despite this, the survival is more or less 30%. And what is the most important, the most of the survivals have good neurological outcome. So the key message is, again, in hypothermic cardiac arrest, very long low flow or no flow, so the analysis cardiac arrest, and the high rate of asystole does not translate into the poor prognosis. In addition to the pre-hospital data, we very often use the bedside gases and ETCO2 to decide about the prognosis and for the further treatment efforts, and also the quality of ongoing CPR. But in hypothermia, as Professor Kosinski mentioned, this can be very tricky, because when the temperature falls down, the solubility of gases increases, so the oxygen and carbon dioxide partial pressures are very low in vivo in our hypothermic patient. But if we take the blood sample, if we measure the blood sample in our analyzer, it will always warm this sample to 37 degrees. And at 37 degrees, part of these gases came out of the solution, and the machine reports high PO2 and high PCO2 than the patient really has in his blood. And in clinical practice, we simply use the standards, the uncorrected numbers measured at 47 degrees, and we don't try to fix them to the patient's temperature. And why is this important? Because if we want to interpret the study by Professor De Rocha, comparing hypothermic and normothermic cardiac arrest, what we notice is that at the hospital admission, ETCO2 in hypothermia was very low, with a median of approximately 12 millimeters of mercury. And what's more, about half of the hypothermic survivors had the ETCO2 below 10 on admission. When we corrected the PaCO2, so the partial pressure of the carbon dioxide, to the patient's temperature, it also goes down with hypothermia. So now, if you follow these 2 curves from the graph, the red one and the blue one, so as the core temperature falls, so we move from the right to the left, you can see that both ETCO2 and TC-corrected PCO2 falls down. And this perfectly fits the physiology. So in cold blood, CO2 is more soluble, more gas stays dissolved, less reaches the alveoli, so we have less ETCO2. So the ETCO2 is low. But if you put the sample in the analyzer, which rewarms the sample to 37 Celsius, this dissolved CO2 comes out of the solution, and the measured PaCO2 is artificially higher than our hypothermic patient really have. This study shows us 2 things. If you look at the corrected values, I don't know if my pointer is working properly, but if you see the corrected values, hypothermic patients have low ETCO2 and low corrected for temperature PCO2. And second, as you can see above, so here, in clinical practice, when we typically do not correct those values, we can find that PCO2 is quite high or even higher than the normothermic patients. And we have very wide PCO2, ETCO2 gradient. This is just because the hypothermia. So in hypothermic cardiac arrest, low ETCO2 is expected and must not be used to stop CPR or deny ECPR. And the same actually is true for oxygen status, but studies in this area are lacking. We are working on some new calculations. Why we think that also beside PCO2, PO2 also is important that if you see, if you check the several major ECPR protocols in normothermia, like Minnesota, like Phoenix protocol, like arrest study, they all require PO2 at least 50 millimeters of mercury, arterial saturation of at least 85, and ETCO2 at least 10 to cannulate. And if this target are not reached, the patient is not just not cannulated. The patient in some protocols is the resuscitation in some protocols is terminated. What is I think shocking for me, that one actually study from NHS, the Phoenix study, uses not SaO2, so it's not the saturation of arterial blood gas. It's the SpO2. So they use SpO2, so the peripheral perfusion, as the stop criterion for ECPR. Yeah, it can be controversial. The last red flag, fortunately not listed as the official contraindication, but we do know from clinical practice that it is actually a parameter that we look at the admission when the patient came to the hospital, is severe hypoglycemia. And in hypothermia, severe hypoglycemia does not preclude good neurological outcome. As you can see from the data from a study of Pluta, over 1/3 of the patients with glucose below 3 millimoles survived with a good neurological outcome, including one patient with 0.9 millimoles, and there were no significant differences between these two subpopulations of patients. So we know that normothermic contraindications do not work well in hypothermia, but there is, however, one point that we all agree, that severe multimorbidity and the end-of-life care are strong contraindications, the ethical contraindications to cannulation. The problem is that at the moment of decision, the pro-hospital informations are very limited. So the patient is unconscious, the family is not present, and we do not have a prior medical history of this patient. So we sometimes have to look at other clues. For example, where the patient was found. It may sound a bit controversial, but statistically, actually it fits. So if we deal with the hypothermic patients found indoor, so we have so-called indoor hypothermia or indoor presentation of hypothermia, it often means that we deal with an older, frail, multiple person with multiple comorbidities, and because they do not leave their homes. Okay? And on the other hand, we have the so-called outdoor hypothermia presentation. So when the patient is found at the street or in the mountains hitchhiking, he usually is younger and maybe more active, as he was found outside. And to bring this idea into a useful tool and to try to identify the patients with poor outcome in non-asphyxial HCA, we developed so-called the HELP score. It uses 3 variables measured at admission and 1 information on the hypothermia presentation, so the indoor versus the outdoor. And we found that higher hemoglobin, the outdoor exposure, the lower lactate, and lower potassium may help us to identify patients with enough physiological reserve who may truly benefit from ECMO rewarming. But this tool is yet to be validated. And as for now, we have only 1 protocol to follow, and we have to stay strict to this protocol. So, if the patient is in the cardiac arrest, so he's on this side of the graph, and the core temperature is below 30 Celsius degrees, we should think about hypothermia as the primary cause of the cardiac arrest, because true HCA is very rare above 28-30 Celsius degrees. In this situation, the patient should be transferred to an ECLS center, and we should calculate the HOPE score. If the predicted survival is 10 or more, the ECLS rewarming is, or the ECPR actually, is recommended. If the core temperature is above 30 Celsius, the hypothermia may not be the primary, but secondary, and the patient should be managed along standard normothermic ECPR pathways, and we should search for other than hypothermia causes of cardiac arrest. But this is just the concept. I know this is in the guidelines, and this is very useful tool, but the decision to provide ECPR standard CPR or to terminate the resuscitation should always be based on, I think, consensus, not just strict cutoffs, because at the end there is a patient, not the numbers. Okay? I also have just 2 slides to show you how good actually HOPE score is. Mathieu said this is kind of the same, because if you look at the HOPE score cutoff, so it was 10, it was set because the sensitivity was 100% at this threshold and specificity was 51. We have all the data which can be used to calculate something called the net benefit. So using HOPE with the threshold of 10, we have we say that 34 additional patients
We probably lost Konrad again. So there are some minutes left. Then I would like to go back to the first questions put on questions and answers about the experience in pediatric praxis. So Sylveriusz and Mathieu already put some references on this, but maybe Mathieu, Sylveriusz, could you comment for the audience about the eligibility of a HOPE score for pediatric patients, and how to, is there any special difference? I mean, rescuing kids is always a difference because they are kids, but do we have to concern maybe different issue in the logistic, or I mean, they may be put on bypass and not on ECLS. I recently have heard from some pediatric people from Canada. So maybe you could comment on this.
Well, a hypothermic cardiac arrest in pediatric population is a very, very rarely incidence. So as I wrote it down, we have several cases in Poland, but no one of them I was directly involved in. So it's difficult to comment such a question. I might say what what would I do if I were in such circumstances? If I have a pediatric patient, I wouldn't look for any prognostic factors or any expectations. I would just use the ECLS just for psychological point of view.
Mathieu, any comments from your side?
No, I have the same opinion because calculating the survival probabilities is good, but if you are 95 years old or 5 years old, you have also to include the life expectancy of the patient. And I put some references on the site. One is a theoretical discussion, Rousson, Valentin et al., the survival probability cutoff depending on the age, notably. And if you look at the literature in the hope derivation and validation study, we had 60 or 80 pediatric patient. So it's also validated for children. And interestingly, we had two references that were published, one this year, which is Skyfe collaborators, who are from Salt Lake City and published a consecutive case series of patients, and all with a hope score, patient with a hope score of more than 10%, all but one survived. So this is why the AHA suggested a cutoff of 5% for the children. And another paper, which is in the letter, it's the systematic review, including case reports of pediatric patients who survived with hypothermic cardiac arrest following ECLS. And here again, the hope scores were always more than 10%. But again, like Sylveriusz, I would more played for, okay, if you have a pediatric patient and the possibility that hypothermia may be the cause of the cardiac arrest, just rewarm the patient and see what happened.
Exactly, and also considering bypass in a cardiac surgery. So even if there is no because ECLS is not a viable, it is a very rare condition. So and ECLS is not available for kids at every center. So also bypass at pediatric centers. Pediatric cardiac surgical centers can be an option, as I previously said. So we still have two open questions. I suppose Konrad is back, but our time is very limited now and advanced. So I would rather focus now for the two remaining questions. This is about how many minutes we can do CPR before starting ECMO in case of hypothermia. I suppose this was Sylveriusz. You had or some of you showed this case from Spain. So it was more than 5 hours. There are also cases when something like maybe 7 hours were reported. Please correct me if I'm wrong. What are how is the longest CPR documented CPR before ECLS rewarming? Could you comment on this?
I would say 6-7 hours, but it's not a matter of beating records.
Yeah.
In my opinion, as the longer the CPR, the longer the transport. That means that the system which we created failed. And this should be remembered, that time is life. Hypothermia has a protective effect, but not for a number of hours. So we have to use all measures to be as fast as possible with transport, with rescue operation, as quick that the patients gets to the ECMO center, the better.
Exactly. So this is one of the messages, and then we have another question about if the patient is not pulseless but hypothermic and at risk for instability, arrhythmias, etc. Is it better to rewarm when ECMO is available? And maybe I would comment by myself because as we started with our first manuscript about this narrative review and then developed the guideline, we always put attention not to use this term ECMO is for rewarming, because of course ECMO, this is like an additional tool for rewarming. But what we are doing during ECLS is organ support and rewarming. And this is, from my point of view, the main message to you from our webinar today, because you have to consider and remember that rewarming patient in the hypothermic cardiac arrest is also organ support, or mainly organ support. Those patients are in a severe multi-organ dysfunction, and you need also ECLS for organ support, extracorporeal organ support first. And for this reason, we published this ELSO guideline to emphasize not only rewarming with ECLS, but organ support. So, and the last question, does the ROSC definition, 20-minute sustainable ROSC, differ in accidental hypothermia and ECPR for hypothermic patients and normothermic patients? And also I would say no, and this is what Sylveriusz also said, and you showed this in your slides at the first presentation. So the criteria for ECLS in hypothermic patients are completely different than for normothermic patients. So please take these two home messages first from our webinar. I just received the message we have 5 minutes left. So I would like there are no more questions on the panel. I would like to thank all the attendees who were with us during this webinar. We have had, in the meantime, I checked, more than 140 participants, and I would like to thank you for your excellent presentations and for your time. So see you for the next time, and have a good evening. Bye.
Thank you very much.
Bye-bye. Thank you.
Thank you. Bye.